let's go ahead and introduce our speakers for today. So we're excited to have Dr. Max Sungurov, who's a principal at Medicare Advantage MLR Solutions, and also the Chief Medical Officer for MA Plans at BCBS of South Carolina. Max is going to be our primary presenter today. And we're also excited to have our own Praveen Gulia, who's our Director of Risk Adjustment and Quality here at Inova. So with that, let's go ahead and go to the next slide. And we've got a question that we'd like to ask you all. There we go. So we wanted to start off with a question, and it's when MLR is under pressure and you want to improve it as quickly as possible, but you can only take one action. What is it that you bet your budget on? So we've got 5 choices here. So look them over and drop your answer into the chat. A, intensify utilization management. B, optimize care gap closure programs. C, invest in optimizing risk capture. D, focus on effective care management. Or E, develop additional value-based contracts with providers. So while our participants are doing that and thinking that over, I'm going to turn it over to you, Max, and let you introduce yourself quickly and take things away. So, Dr. Max.
I'm Max Sungurov. I'm a physician, an internist by training, work for Blue Cross Blue Shield of South Carolina as a chief medical officer for Medicare Advantage plans. I do also an independent consulting work for my own company. I also am a member of the editorial board for Population Health Journal. So I do work a lot in the area of population health. My passion is pragmatics. I'm very passionate about pragmatic solutions. So anything and everything I do, I try to get to the bottom line of what's doable, what's not doable. If I looked at this first question, and please allow me to give you my personal opinion here, I think I would go with answer A in the most immediate, with the most immediate horizons of control and spend. That, however, has a lot of headwinds now with the various audits that CMS conducts and various limitations that we have. And it probably is not a long-term solution, because if you over-tight utilization management, you most likely will end up scaring people away. But this is what I do most of the days. However, in the longer run, and maybe with the horizons of at least 12 months, I would use the answer C. And I think this is the main topic of our today's conversation. So we can go to the main slide. I don't know what the audience prefer, but that would be my answers. Let's go further, Derek. Yes. So let's talk a little bit about the MLR fundamentals here. So the MLR fundamentals is that medical loss ratio is basically a ratio of medical claims expense and premium revenues. For the purposes of this discussion, we combine medical claims and Part D claims as well. And we also combine revenues coming from Part C and Part D. So on the premium revenue side, what do we have? What are other options, our sources of revenues? So we do have premiums. Though member premiums are now only probably 33% as of 2026, only 33% of plans that use member premium, 67% are free for members, and various cost sharing streams, whether it's co-pays, deductibles, co-insurance, maximal out of pocket, and benchmark payments that we get from CMS, depending on state, county, age, gender, institutional status, whether it's a community dweller or someone who is in a long-term care facility, disability, and so on and so forth. RAF score, and that is the big part of today's conversation. That is based on combination of hierarchical condition categories. individual categories and their combinations. And of course, stars is a big source of revenues. The star bonus varies from 5% for 4.5, and 5-star plans. In addition to that, plans get rebates from CMS, up to 70% for 5-star plans. So as a result of that, the target MLR allowed by CMS is 85%. But as you know, this target is very elusive these days, and the majority of plans that at least publicly reporting their MLRs easily hitting 90% at this point of time. Then if you add administrative expense, that it can, of course, varies depending on the plan. But let's just say that this is somewhere between 6 to 12% or so. You would add that to the MLR, and the rest is effectively your net profitability, which becomes a problem when the MLR is growing, as well as when administrative expenses are growing. MLR is growing because of the growing utilization and growing difficulties to generate revenues. Both are big factors of rising MLR. Administrative expenses are growing basically because any plan that I can think of is facing the need to beef up their administrative expenses in order to get better in their stars, gap closures, risk capture, and so on and so forth, and as well as just to stay compliant with the CMS regulations, to provide appropriate governance and oversight and things of that nature. And so net profitability becomes extremely sensitive because of that. So if you think about a plan that hypothetically had a profit margin of 3% with a year before with MLR of 85%, if your MLR moves up just 1% to 86, then your net profit margin just drops to 2%, which effectively is a 33% drop of the profit margin, just from 1% increase in MLR. Let me pause here and ask if the audience has any questions about the MLR itself. Okay. By the way, feel free to interrupt and or raise your hand, and I'm going to ask Derek to monitor that. You also can put your questions in the chat. Happy to address them as we go along, or happy to address them at the end. However, encourage you to feel free to ask them as they pop in your heads. All right, let's go to the next one. Next slide. So the topics of today's conversation, we decided to address a few interesting topics. One of them would be the discovery that we have analyzing the medical loss ratio of various cohorts in AMA plans, that a lot of high risk or high MLR members, like just for simplicity's sake, we'll say MLR over 100, although we understand that for profitability purposes, even members with MLR 90 or 92, 95 are high MLR members. So the discovery is that a lot of these members are actually undercoded and not necessarily overtreated, or not necessarily exhibit high utilization patterns. We will also talk about potential improvement for current MLR strategies that plans can implement. We'll discuss separately the topic of fragmentation of current risk adjustment processes and strategies and workflows, and their impact on administrative cost and on the margins of MA profitability. And we will talk also about immediate and scalable MLR improvement that plans could implement. Okay, next slide. So I just want to make a disclaimer that a lot of the slides that you see in here is a result of my personal work. I'm not necessarily sharing opinions of Blue Cross Blue Shield, and like, for instance, this slide is the one I built trying to express my understanding of population health. So let's look at this slide and let's see what big pillars of population health exist. So on one end, you have a whole person care approach. So what it is, it's basically a longitudinal health span over years of an individual member being with your plan. That would include anything from medical to behavioral to pharmacy to social determinants of health to utilization and so on and so forth. So anything that you can think of that person represents to the plan. The second pillar here is member engagement and retention. The churning is real, and people churn. They move from plan to plan for various reasons. Sometimes monetary, sometimes customer service, sometimes because they relocate, sometimes because plan change their design, and the design of plan doesn't fit the needs of the patient. Sometimes of supplemental benefits, and various reasons. But what typically you see is the cost of acquisition of a new member is pretty substantial. It varies depending on the size of the plan or regions, but let's just say that the cost of acquisition of a new member would easily exceed $1,100 or $1,200. And then the third pillar, which is completely essential, and often this pillar is not in a consideration when we talk about things in population health. Population health is funded by risk adjustment effectively. So if there is no revenues, there is really no meaningful population health in any way. And that is something that I think is very essential to understand. So the goal of any interaction with a member of the health plan is to really address all three aspects of that at once. So the health and the utilization, the engagement, and the risk adjustment. And of course, this has to be based on actionable analytics and real, ideally very intense data insight that has to be maintained and developed as time progresses. Okay, now we can do the next slide. So let's look at the hypothetical plan that has 100,000 members. So just a hypothetical smaller size plan. And this is what would it would look like if you subdivide the population into 4 cohorts. On the very left side, you have no claims. So let's just say in a 100,000 member plan, most likely you will see somewhere between 1,500 to 4,000 members. And for this purpose, we'll just use a number of 3,000 just for illustration purposes, the members that have no claims. So they bring you revenues, which are purple here, and there is no expense. So the MLR is effectively 0. So these are the most profitable members that pretty much every plan would have. Some of them would get their care in VA facilities. Some of them just don't go to the doctors. The big problem with this is that we don't really know anything about them. No claims, no knowledge about these members. So as highly profitable they could be this year, a couple of things will happen to them next year pretty much unavoidably. One is that there will be no risk-adjusted revenue coming next year. So even if they currently risk-adjusted next year, they won't be. So your revenues will drop. So that's number one. Number two is that if there is no interaction with the plan, there's probably no engagement. And so the likelihood of them churning is also pretty real. And lastly, just like on the previous slide, we talked what's the third one is their health. We don't really know what's going on with them today. We don't know what's going on with them tomorrow. We definitely don't know what's going to happen with them next year. So a lot of these members can potentially deteriorate dramatically and quickly move from the cohort on the left to the cohort all the way on the right. The cohort on the right is the cohort with MLR over 100. I gave it 23,000 members. This most certainly could be less, fewer for some plans, or slightly more for others. But this is the cohort where in red you can see significant cost. That cohort, as we will discuss further, may include members with some serious medical conditions and not necessarily also only It could also include members who just high utilizers, include members who are in the last year of life, who are frail, who demented, and so on and so forth. And then everything in between, and the members that are whose MLR is under 100, but more than zero. So the largest cohort, most likely would be the cohort of members whose MLR is under 85%. Pardon, it's a typo. Has to be under 85%, right? Because that's a cutoff by a CMS. So this is the MLR this MLR in this group. Most likely, you will find that this is the largest group, significantly larger than any other one. But in this group, you probably should anticipate that the medical loss ratio would be somewhere in the vicinity of 50%, 55%. So the average, the mean, would be actually significantly lower than 84. Okay, we can move to the next slide. All right, so now let's look at the cohort that is typically in focus for most plans. It's the cohort with high MLR. So who is in this cohort? Most likely, this cohort will include members with, again, in the last year of life, whose MLR may be 300, 400, 500%. There will be members who are frail, and maybe they are approaching their last or end of their life. This most likely there will be members with multiple highly complex and severe medical conditions who frequently get admitted to hospitals, use emergency rooms, and so on and so forth. They could be also members who have predominant psychiatric conditions that are very difficult to manage, including some severe addictions, who also find themselves admitted and readmitted, and so on and so forth. They will be members with chronic kidney diseases, higher stages, potentially members with complications of diabetes, members with stroke, and so on and so forth. The key message here is that this cohort, generally speaking, is supposed to represent a higher complexity of medical illness, but does it always represent that? What we're finding is that if you look at this cohort, there is most likely you will find that at least a portion of, and I will be more specific with the numbers, at least a portion of these members don't have proper risk adjustment. So they end up having MLR over 100, not because they are super costly. It's because the proportion of their cost to the revenue is simply over 1. And they become, essentially they become non-profitable or create a loss for the plans because of the inadequate revenues. So what do we do with this cohort? What would be the population approach? Now, this is not meant to be a complete list, but just to give you some ideas of things that are opportunities for us. So we want to have a robust care management and, of course, provider management. And, of course, we would like to engage these members to participate in their own health. It's the most important thing. Not necessarily engage with the plan, but engage with providers, engage providers with the plans, and so on and so forth. Another good example of opportunities here, significant portion of the total spend in pretty much every plan, somewhere between 6 to 10%, let's say 6 to 8%, would be the end of life. The end of life spend that is particularly significant in the last couple of months of life. And as you know, on average in our country, the hospice care is involved 19 to 20 days before a person dies. And oftentimes it actually gets involved when the person is already admitted and maybe 1 or 2 or 3 days before their last breath. So the opportunity here definitely is launching advanced care planning and palliative programs and make a conscious effort to limit this wasteful spend and provide people with dignity and pain control and just overall comfort in order for them to deal better, cope better with their illnesses at the end of their lives. And of course, there are big Ds: dementia, diabetes, and depression. Most of them would be in this group. By the way, for example, depression typically impacts the cost of other chronic illnesses such as COPD, CHF, or any others by significant factor. We're finding that if you have a major depression that is not adequately treated and COPD, then the cost of management, the total cost of care here may be 80% higher than a comparable member without depression. The same applies to dementia, which is that is very prevalent, but not necessarily identified. And I think we have a separate slide for that. The data support that the prevalence of dementia currently may be Alzheimer's dementia only. I'm not even talking about all other forms of dementia, but the Alzheimer's dementia only in the population over 65 years of age could be up to 10%. And it probably is not what you will see if you look at the HCC codes for dementia at least in most plans. And the diabetes and their complications, of course, is a big factor here. So there's plenty of other conditions there. But the key thing for this, and we'll elaborate on that, the most immediate action that you can take that will probably be most effective is to optimize the risk adjustment for this cohort. So based on the MLR-based population segmentation, we established that the meaningful share, and it goes from plan to plan. I've done this work with more than one plan. The meaningful share of members with MLR 100 are not purely cost problem. So most of the time, plans would first try to focus on cost containment, which is a reasonable thing to do. This is my main job, is to provide cost containment and manage MLR for our members through cost containment. So I am fully in support of that. However, going back to the opportunities that we discussed earlier, there's always this big three. One is cost containment and members' health. Two is engagement, and three is funding of all of these activities, which is the risk adjustment effectively. So the conservative estimate, and that probably would be very, very dependent on the plan, but the conservative estimate could be that up to 50% of members who are in that quote unquote expensive cohort with MLR 100, that they have rough scores that are not really fully reflective of the severity and complexity of their conditions. So the opportunity is always there. And even if it's 10% or 20% for your plan with any robust program, please remain open to that consideration. And the message here that oftentimes we hyper-focus on high utilization. However, utilization management as well as care coordination only offers certain opportunities because the medical trend is, let's just say in the MA in general, is somewhere between 3 to 7%, depending on the year, maybe 4 or 5% on average. With that medical trend, the true opportunity of utilization management, care coordination to actually reduce the total cost of care is probably limited, because in order for you to conquer the trend and just to keep the trend at bay, you would need to effectively reduce your spend by 3 to 5% every year, or 4 to 5% every year, which is not an easy goal. And so that hence the opportunity with risk adjustment may be the best of all. So before we have a conversation about spend reduction, we would like to make sure that we paid accurately for the risk that we already bearing and caring for. Any questions here? Okay, so we can move on to the next slide.
All right, Max, if you don't mind if I take this one.
Yeah, go ahead, Ashutosh.
Yeah, right. All right. So I'll be talking more on the lines of provider documentation and coding, and how these are significant contributors to risk scores. And basically, we want to discuss about the impact here. As Dr. Max has already introduced, that dementia is fairly common in the Medicare. It's highly prevalent in the Medicare Advantage population, and it represents a significant clinical burden. It is closely tied to age-related frailty, as he explained, which often result in costly complications, hospitalizations, and rightfully, this burden is reflected in the relative high risk score, which is assigned to dementia. So we're talking about dementia here. So, and we also want to talk about what health plans face as a two-sided challenge with dementia. Uh, Obviously, when dementia and its complications, there are a lot of complications with dementia. There's depression, there is agitated behavior, and then there are some not directly related complications like malnutrition and all that. They are not very accurately documented and coded. That is probably the challenge one that the health plans face because it is not properly documented. And plans absorb the clinical cost without the corresponding risk adjustment revenue. That is the challenge number two. So it's a two-sided challenge that health plans face. Now, the risk adjusting diagnoses are heavily dependent. We all know it's heavily dependent on PCP documentation. Dementia being a neurological disorder, PCPs can use, or they often use dementia, Alzheimer's interchangeably. They sometimes they rely on just documenting the symptoms like forgetfulness, which will obviously not risk adjust. So, and on top of that, dementia coding is quite complex, as some of the coders, I'm sure, uh, people with coding background here will agree with me. It's one of the more complicated ICD coding when we talk about dementia because of all the associated complications and how the documentation should be inferred as. So these are the significant challenges which affect the documentation and coding to the detriment of the risk scores. Now, a lot of targeted provider education and CDI to reinforce accurate terminology, disease status, and documentation of management and complications. Uh, we can see there which are focused on dementia, which kind of confirm what we just said, and accurate coding also focused on dementia specificity, staging, complication capture. These are a few measures that are uh, usually taken to improve the coding and documentation of dementia. So, and what we believe is improved documentation, and we have seen this with some CDI and prospective programs where we have worked with providers. We have seen that improved documentation actually leads to better clinical insights and proactive management. I mean, we can't say that there's a substantial data to support that, but in practice, we have seen that the documentation. We always say that management reflects in good documentation, but we have also seen that an effort in great documentation reflects in better uh, clinical management also of conditions. And when effectively implemented, these measures, they definitely improve risk scores and risk adjusted revenue improves at a population level because it's significant population that uh, that is affected with dementia. And health plans achieve better alignment between the clinical burden and reimbursement that we are talking about earlier. Good documentation, not just risk scores. I want to also touch upon quality. So good documentation supports quality outcomes as well. Uh, One example that we can take here for dementia is use of antipsychotics in dementia patients. It is a Part D quality measure. So great documentations it just doesn't affect positively the risk scores, also impact the quality scores, star ratings, and everything. And we just wanted to use dementia as a great example, as Dr. Max also suggested that this is a significantly prevalent condition and also not greatly reflected in risk scores. Uh, I'll take a pause here, Dr. Max, you can continue, or if there are any questions, we can answer those questions.
Thank you, Praveen. I would like to add that an interesting observation that we had is that our members with dementia, as they transition from mild cognitive impairment into mild dementia, moderate dementia, and severe dementia, their lose their executive functions. So a lot of times that if a plan properly identified mild dementia, it's not as unusual to see mild dementia not diagnosed really. Severe dementia usually is well diagnosed. However, if you look at mild dementia, uh, at the point of time when the executive functions are not fully lost, this might be the opportunity for the plan to address the advanced care planning with those members and not defer it to either chance or last moment family decisions. Um, so that is another aspect of why it's so important to capture dementia. Um, uh, there's more questions, but I will save them for the end. Let's move forward
But
here.
Max, I wanted to ask you a question. I'm sorry to interrupt you.
Sure.
So we talked about the documentation challenges and coding challenges. From a clinical perspective, I wanted to ask you, how big is the challenge of underdiagnosed? We all talk about undercoded, and poorly documented conditions, but how about underdiagnosed, the conditions which are not even diagnosed? Like dementia could be a condition because the diagnosis is very clinical in nature. So, what is there a significant burden here that the conditions are not diagnosed at all on time?
Yes. In the sense of dementia, was the example I was given earlier is that if you look at Milliman regional reports of prevalence of HCC of dementia, for example, in the South where I practice, I think we are at about 3.6%. That's the prevalence of diagnosis of dementia. So that means that at least another 6 or 7% of folks are just simply not diagnosed. So it's a challenge, definitely challenge. And a lot of times those things can be, they're not focused on. The example here would be if you looked at someone, if you try to test someone for dementia, and you have a task of testing 1,000 members for dementia, it's kind of difficult, right? Where would you go? Would you go for somebody who's 67 years old or somebody who's 87 years old? So members who are between 65 and 70, their likelihood of dementia would be less than actually between 65 and 74. The likelihood of dementia probably will be 5% or less. Whereas if you go to the group of members who are over 85 years old, the likelihood of dementia probably will be in excess of 1/3, so maybe 35, 40%. And so the opportunity is by actually being nimble and identify those segments of population that would benefit the most from testing or exploration of the charts and so on and so forth. So a simple example of age-driven targeted HCC evaluation or search for diagnosis could solve a lot of these problems. Hope this answered your questions, Ashutosh. I'm sorry, Praveen. So let's move forward to the next slide to stay on time. So another group we talked about problematic members, but now we do have members whose MLR is very favorable to us, so they're profitable members, right? You can see we're going to focus on the quote unquote profitable members. What will we do for these members? Well, first of all, we need to engage these members in their own health, because if they're not engaged, they're not going to stay there. The natural progression of disease is always from left to right, the right being more severe conditions, so or more severe status of the same condition. So ideal situation is to identify, stratify their medical condition early, when they still could be some things could be prevented, complication can be contained, and so on and so forth. So this is an opportunity to engage these folks, and also engagement will reduce the chance of these folks leaving the plan. And we already talked about churning and the cost of the acquisition of new members. So maintenance of quote unquote good health. A lot of times we don't really know if they have good health. We just know that they are. We don't pay much for them, but it's absolutely essential to identify and stratify to prevent rising risk of condition deterioration. And this is a strategy that we're actively using right now in our workplace to look for the rising risk identifiers. And of course, absolutely essential part of all of this is you have to risk adjust this members for the next year revenue. Some of these folks plans inherited from other plans, and they just have, or actually they just newcomers, right? to the plan, and they may have been risk adjusted before, but they're not risk adjusted as actively right now. Some of these members, simply speaking, didn't go to the doctor because they felt better to some extent this year than they felt the year before. So there is a lot of different considerations. So a key factor for funding all of the population health interventions and actually taking care of these folks is engage them, bring them in, risk adjust them, take good care of them. So we can move to the next slide. So I guess this is something that we talked quite a bit today, is that the current year MLR is definitely constrained by the revenue inputs, benchmarks, premium, stars. All of this is predetermined either last year or the year before. The most of the cost levers that we have, they either moving slowly or they could be less impactful. I'm sorry. So somebody said something. Can you hear me?
We lost you for a moment here. So
okay. Can you hear me now? Can you hear me?
Yes.
Hello?
Yes, we can
got you, Max.
Okay, sorry for that. I didn't move. I was here. So most cost lever, care management, utilization management, value-based arrangement, pop health, they're all moving relatively slowly, and they may be less impactful. Or even if they are impactful, there's plenty of regulatory constraints and considerations that keep on coming to us. So that's a problem. They're still extremely valuable. But probably at this point of time, still, despite all of the regulations and restrictions that CMS imposing on us, including the ones from the day before, the risk adjustment still remains the only proven lever to predictably and reliably impact MLR within 1 year cycle. So cutting medical costs over a short period of time it's desirable, but kind of difficult to do, if not impossible most of the time, with the exception of some very, very strict utilization management practices. But an opportunity always remains to correct under captured risk. That's the main message from this slide. Let's see what we get next. Why don't we address this question? Could you read the question for me?
Sure. Is RAF not fully reflected due to poor coding only, or undiagnosed conditions also have a significant impact? So the impact of the undiagnosed conditions on the RAF.
Both. This absolutely correctly. So undiagnosed conditions, of course, are there, and it's not always possible for the plan to really impact that, because ultimately it has to be physicians who diagnose these conditions. However, or care providers. However, to answer your question, of course, plans have some opportunities for that. So some conditions can be predicted because there's enough predictive analytics to suggest that certain conditions are likely going to be present or already present. And so that's number one. Number two is that, of course, we have health risk assessment surveys. Of course, we have various communications with members. So all of those things are potentially doable. So we can, even if we don't have our own, let's say, if we're not a vertically integrated health plan system where we have our own providers, or we don't have AHR access, in those scenarios, we still can identify, and we do identify a lot of those conditions. But the bigger thing that is completely on the surface is to capture and recapture the existing risk and documentation. So, okay, so let's talk a little bit about, this is the slide that I would like to ask Ashutosh to, I'm sorry, Praveen, apologies, Praveen, to comment on.
All right. Thank you, Dr. Mike. Obviously, a lot of points and a lot of efforts that are required. We have established that risk adjustment is the biggest lever here, and it is easier said than done, right? So revenue from risk adjustment is not a simple game. Requires several efforts, right? And it's like buying a used car, if I may give an example, right? If you might get a great deal here, but if you end up spending a lot of money and costly, maintenance costs, you end up losing that money that you saved. So same story with this administrative cost, which I feel that you might hit the golden target of 85% MLR. Uh, but if your administrative admin costs are significantly higher, you don't see a lot of that money, in short. And the administrative costs tend to be higher because obviously their efforts are quite complicated. And over the years, to achieve accuracy of those efforts, these efforts have been really specialized. And these efforts are done by specialized or people with special skills, or not special, I'm saying people with very unique skills, right? So a CDI guy will do CDI, and someone who's doing prospective coding will do prospective. And you have retrieval guys, and you have vendors who are doing very specific things in risk adjustment, which is great to achieve that. We want to achieve that specialization to have a great accuracy, but at the same time, we know that a lot of efforts here, a lot of steps in these efforts have duplicate steps. Say, for example, uh, chasing records or retrieving records. Records can be retrieved for the MyHEDIS season for the hybrid measures. Records can be retrieved for review of HCC coding, or if someone got a RADV notice, then the health plan will retrieve records to find out the best records that support HCCs which are under question. So there are various reasons why the records are retrieved, and various other reasons why the records are reviewed for various efforts. And we have found, with experience, we have found that a lot of steps are duplicated. And I think it's a uh, it's a very popular concept nowadays, bringing quality and risk together. That is, we have seen a lot of events where this topic has been picked. And what we really want to say here is that you can uh, optimize the efforts. You can optimize the efforts to get maximum out of these. But then uh, the limiting factor could be a great vendor who can uh, do HCC coding while abstracting the hybrid measures. Or let's say, for example, a prospective review. Someone doing a prospective review for CDI and recapture with a look back of 1 or 2 years of records in the EMR system. You can modify that and add more points to it, more metrics to it, and identify the best encounters from the previous years, and refine the recapture rates by removing the false recapture targets if conditions are resolved. And you can do CDI pre and post visit support. You can improve provider documentation. At the same time, uh, these look back reviews can be looked as retrospective HCC coding as well, and why not? And a lot of efforts efforts require creativity, and health plans need to get more creative, need to find vendors who are flexible for these creative ideas and can offer you solutions without any impact on quality which comes from the specialization of efforts. You can still have that accuracy of efforts and still maximize or optimize uh, the output of these efforts by adding more points to it. I mean, we have done a lot of specialization, and now clubbing efforts together doesn't really mean that we will lose that accuracy of specialization. It can still be achieved. Just like in medicine, now PCPs are considered a very significant uh, contributors to health, because uh, they are the gatekeepers. They manage and they treat a lot of conditions, despite the conditions being specialized, just like the example that we had for dementia. PCPs do diagnose, manage, document, and manage these conditions, like specialized conditions which are usually treated by specialists, but PCPs are managing them, uh, like diabetes, hypertension, dementia, depression. These things are being managed. Similarly, uh, the vendors who specialize in various efforts, if if you can identify great vendors who have uh, great qualities and have experiences in various fields, can get creative with them and remove the duplicate steps in a lot of efforts and maximize the efforts, bring CDI, prospective coding, concurrent and retrospective, finding best encounter, RADV readiness, all of this you can, and the quality measures and finding the care gaps, all of these things you can bring together. And it is going to be complicated initially, but it is definitely worth the effort, and it will not take much time for health plans to see the benefits of consolidating these efforts. Definitely will not lose the accuracy of efforts, but at the same time will make these efforts a lot more efficient.
Thank you, Praveen. I'm going to quickly answer a couple of questions before we move on to the next slide. So how to plan risk for one of the questions came from how to plan risk for new members differently. Well, if the new member comes from your own commercial plan or any other plan, ACA, there's of course an opportunity to evaluate these members and get all this information and sort of project your future expenses for the year after. The first year, no matter what, if the member new to Medicare, there's no risk adjustment payment here, but nevertheless you can prepare and know exactly what to do, and at least on the cost containment side of things, you can probably engage this member as soon as they arrive to your plan. If you get a member who comes from another plan, it could be a problem, most certainly a problem, because you're dealing with a risk adjustment effort from a different plan. So effectively, you don't know if the risk adjusted well or not. So there's really no way to know this kind of thing. So this is the new member is of course is problem. Somebody came to your plan and was diagnosed with metastatic cancer. It is an issue. So, or had a stroke, and nobody was prepared for that. So, but that evens out as time progresses, as long as you're doing the right work in order to risk adjust them. Another question was how much room do plans really have to influence MLR once the year has already started? That's a great question. I would think that the main opportunity of influence on MLR during the year, once the year already started, you cannot change plan design, you cannot change cost sharing from members, you cannot change RAF. But what you can do here is probably the levers to use from that three circles that I was showing you. The levers here would be number one would be engagement, whether it's engagement on pharmacy management, on care management. They're not easy tasks. They're not easy tasks. And of course, optimization of utilization management is the fastest turnaround, but not everything can be achieved through that. So let's go to the last slide. I think we have one, maybe slide more. So I think it's to summarize that the big things to get right for this year is to recognize that most medical cost controls, including contracting, have some kind of multi-year curves, and the impact is going to take longer, and the pressure that we experience in MLR, they're currently there and it's just growing. So it's just a fact. The treat risk adjustment as the most immediate and scalable lever is absolutely important, because this is what our best way to align our revenues with the disease burden. Effectively, if most of the time the high MLR reflect lack of such alignment, so systematically identifying and stratifying rising risk in healthy, quote unquote, healthy folks, or in population who already have established conditions or high MLR population, so the RAF score reflects true severity and complexity of the condition, existing conditions. That is the absolute paramount of all efforts of every plan. And the accurate RAF score is what funds the population health programs, ensuring that all care management efforts and that the target improvement of members' outcomes, they are funded. And that probably would be the main message here, is that everything needs to be addressed with a high focus on the risk adjustment efforts. I would like to thank ANOVA in the last minute for making it possible for all of us to talk today. And specifically and especially would like to thank everyone who joined us today. We can move to the last slide. Everyone who joined us today and spent the whole hour participating in this discussion. Please take our contact information and feel free to reach out with if what we discussed resonated. I'm sorry, if what we discussed resonated with you and you want to learn more or collaborate. Thank you so much.
Absolutely. Thank you. Thank you to our presenters. Thank you for your patience, everyone. If you have any follow-up questions, please reach out to me directly. Also, we will make the deck available within the next 1 or 2 days. So if you'd like a copy, please let me know and we can be in touch with that. Again, from the Innova side, we support Medicare Advantage plans with high-yield chart retrieval and RA coding solutions. If you'd like to learn more, please let me know that as well. Thank you, Dr. Max, Praveen, and everyone. Have a good rest of your day.